Four Seasons. We were talking about the transition to Kaiser, and just the next thing and everything else, and what we need to do. And I had no answers. So that's why I'm asking you the question. Formulated patient.
Patients, we got no patients. Half the people I see.
Okay.
So there's no.
Well, my company next year won't even do our premium PPO. They really want us to go to Kaiser or something else.
This is
Oh.
a big reason for us.
What is that?
State prisons.
You have to.
You can't get see that kind of cost. Because big accounts don't do it.
Today.
And regional health systems that don't have one national system, just simple.
And they said my premium PPO will not be available next year. And they just said it. So they offered Kaiser and Select and something else. And then you get, so it's kind of interesting. Yeah, I don't know Kaiser.
Does he know your insurance?
Everybody knows these children.
Everybody.
He knows.
Yeah.
I'm saying it's like, I'm not saying why we are seeing all these
From the,
patients.
so the roots were very similar.
Okay.
Every day, I'm saying how these
Yeah.
guys
They're the ones successful.
Yeah. Well, group health has always had a great reputation. Kaiser, I don't know at all. And,
by average
you know,
cost.
at my age, you know, hypertension, I get it once a year. And probably an injury, if you know what I'm saying. Yeah. And usually it's weird. And, but you know what I'm saying. And I'm wondering, is it really a good system?
Yeah.
Okay. Well, I don't know.
Very-
That's why I'm
very
asking.
focused on
Okay.
preventive health care, so.
Okay.
Connection.
What, are they going to make me walk or run or something?
You're no chest pain, you're gonna get on the treadmill somewhere.
Hey.
Good morning. Finally, I've been hungry all morning.
So sorry, Jerry.
Can I help you? Are you good?
Oh no, it's good. Easy. Thanks.
This is Julie. That's my Novartis partner.
Hi. Nice to meet you.
So it's one proof.
Oh, that's the theme. Families into.
Review rules, make sure people get what they do.
Oh, we're going to sound like Portland tomorrow. We have a friend that plays for, so we're gonna go take my mom. She's never been to Portland. And I live there.
I can show you.
Like her favorite team.
Give it 4 weeks and come back. It's not better. By the way, the biopsy said.
I was a little bee. My sister has a little nephew, so everything was good.
Would I miss?
Yeah. Not because normally make it, it's just we don't really care anymore.
I don't know. That's what I'm
He's
saying.
like into Christmas. He's letting me call. Not like really. But he thinks all the presents are for him. He tries to look at all of them. He's terrible sometimes.
So you go to your
Yeah,
primary,
I was babysitting him
and then you
the other
get
day.
a referral, or you just
Whenever he leaves, like find
just
him.
call up and go?
It's a nice surprise this time.
That's actually very good.
My pillow had a huge rolling up on my pillow on my bed. And like he just did everything. But
Yeah.
I think so. I think it's really nice.
I wouldn't say it's easy to do, but it's, you know. Really?
I'm Nick, by the way. I went to Boston Center today. Just introduce myself.
Jamie and Jefferson.
What was your name?
Amy.
I'm Nick.
Nice to meet you.
Nice to meet you. So, yeah, so I work doing the bronchial thermoplasty. It's a procedure that we do for severe asthmatics. Typically, once they've, maybe failed the biologics or didn't qualify or kind of on long-term prednisone, it's been a great option. Just trying to come and meet you guys and see how I can support you. So,
primary care. Yeah, no, my position might show up as a GP.
Never show up.
And
Open the chart, it doesn't show up, just like an allergen. It takes a while. Like this one.
How do you do that? All of your offices?
Just write this now.
regular hypertension is being managed. And like I said, like twice a year I get a look out.
I'm on call. Are you going somewhere? Where? Oh,
Maybe.
Or somebody should
Traffic
be
is pretty terrible.
managing 23-year-olds. I need
After the accident.
I-5 still closed. And then,
Yeah, but by the weekend, it should.
By the
It
weekend.
doesn't matter.
hopefully,
Hopefully.
hopefully.
I take the train.
The train should be the safest.
There was a report last night that said that coming into that curve where it derailed, that the train was doing 81 miles an hour and it's at 30 miles an hour.
It was supposed to be going 30, yeah, I read that too.
Yeah, that's pretty crazy.
Really nice guy, nice staff. I see him.
Right. I mean, if I say,
Like over the last few years, and happened multiple times where I've tried as an accident.
where do you go? What do you
Like
do?
in New York once.
Yeah.
I know.
There's a New York that's
Yeah.
You know, he's never had a problem. I've had an MRI, and I've had allergic few times when in New Jersey cases. And he has no problem doing those things. But I probably can't use them. Well, I can use a mixture, but not here. I know you can't answer that, but what I'm saying philosophically. Yeah, philosophically. Because right, and it's, you know. Yeah. Okay. So let's say I hurt myself. You know, I've been at the gym, I've been
Basically,
or something like that. Can I come in? That's fine, but I mean, you're telling me things I didn't know.
That doesn't come out for years.
Is more acute.
Okay. Yeah. But you guys are in Bellevue. Is there anything on this side? Because I live in Magnolia. Go to
There's
the
a
main.
downtown clinic.
I didn't. Where's the downtown? Oh, I know Capitol because I know the allergist there. Because he's out of the military.
Ed, how are you? You feeling better?
Yes.
Good.
So probably
So Andrew's
Capitol.
out. Where is it now? Oh, she's dating Andrew. And so he's out in the back.
Oh, that was.
Or it would let her like her work.
Concession in the back.
I don't.
It's gotta be a really
Well,
small.
they're doing
I
the
think it's all.
doesn't matter. I mean, if I have to go see family practice for a little while, you know, just have the next thing and everything else. Start Sunday exam and say, you know, do this, do that. Let's give it a week. See what happens. You know, so that- Amazon's doing exactly according to general.
At a conference
How you
in
doing?
Alaska.
How are you?
The cheapest flights were like
Can't come.
Iceland Air. But we have like that.
Stop it.
Right.
Don't go there. You know, our image is lower than the
Well, that may not be a good thing to say because it may all be catastrophic.
What I'm trying to say is we're sensitive to the IT.
Good morning. Good. Oh, pretty good. Found a
Or
parking
has to
spot.
start.
Okay, I know.
All the biologics are always very useful.
Yeah.
Stop. No, yes, possibly so. I got news for you. Huge facility also. Okay. And just
It just got here.
Did mine go through? It said it failed.
Asking to.
Another one from Teal.
yeah. So it's really
No,
it's the water, it's the humidity, it's the this, it's the that. And I think a lot of colleagues don't. Yeah. And I keep telling them,
maybe I was in the elevator.
move
Maybe
on.
that's the problem.
You know what I mean? A little something that we can do and say, look what it takes. Yeah. It takes years.
Okay, back on track. So it looks like for that, we're, how much time do you have?
But a rotation is not like a whole one.
Yeah.
That will be hard to. I was just hoping to get. You know, when you order outpatient PFTs, like, I thought,
When they're reading them.
yeah, like just to learn more how to learn better how to read those PFTs.
These are written on some of my consults.
Yeah. Yeah. And,
That's amazing. Are they MDs?
Yeah, I don't know if you could do it just a couple days a week or something.
Yeah, just like.
Maybe just talk a little with Teal. I mean, I may not be here today.
You know, but I don't know, just email that.
From there, talking over. It looks like Trish there is the,
Either like read about sleep or do my
What's
PowerPoint.
her
She the coordinator.
that's Trish.
Are you staying here for the holiday?
Patricia.
Yeah, she ended up doing.
It's the goal to have a full rotation now. Just,
Oh, good. Oh, good. Yeah.
okay.
I didn't know she's had, if she
Yeah,
was
but
a
that's
oral.
not genetic. That might be a little bit. No, I understand.
Yeah,
Because you can't do it.
Look at it.
yeah, just
Okay.
whatever you work out, and then keep Francis informed for that.
Okay.
Say what?
Pretty good.
And we're working on it. Yes, we're working on it. Okay, if you don't mind, I'd like to continue this conversation. Sure. How you doing, Dr. Henderson? Don't shake my hand, walk away, that's fine.
You're being insulted there.
Well, I never.
Merry Christmas to you.
That's right.
How you doing, sir? I understand there's now a conversation about this week.
Probably after.
After the first. And then we start transferring some patients up. I told them that they're employees take baby steps. We'll tell them who's the best payer. And we'll put a couple patients through. And then see what the timing is and everything, and then we'll go through. Yeah, I think it's a very good. And I think he describes it that way. So, yeah. Anyway, big failures you have.
No, but we'll leave a few days for the
So you. Hey, Merry Christmas. That's appropriate.
That's right. That's right. Absolutely. Okay. Thanks.
How was,
You don't return my emails when I text you.
No, but the lefties are starting out here. It's
Do you have that?
It's really
No, I just did. I just
people just
They said that
See, a lot of time for discussion.
Yeah. It only had like 4 electives.
exactly. They know it's right.
Yeah. A couple days.
yeah.
What
do you have
Yeah.
Might as well stay in Miami.
That is bad.
Can you cancel that morning?
All right, so let's get started. The word of the day is pediatric.
We'll talk after.
So today we have Cristina, one of our excellent second-year fellows, who's going to be talking about some research he's doing with Matt and the pediatric asthma patient population. So we're excited to have her speak today. And also, the next 2 weeks we don't have journal club.
Yay.
You can show up here, but there'll be nothing going on. So don't show up the next couple weeks. Yeah.
Thanks for the opportunity to speak and for coming out. I am starting to work with Matt on a project in the Inner City Asthma Consortium, so I thought this would be a nice time to review the literature. It was quite new and unfamiliar to me to kind of get through a lot of it, so I kind of compiled a little story for you and what they've shown over the years, and we'll review what the Inner City Asthma Consortium is. We're going to focus mainly on birth cohort data. I don't have any disclosures. So the outline will start with just pediatric asthma epidemiology, the consortium, what it is, the URECA birth cohort, which is the cohort that was established in the consortium. We'll talk a little bit about the pediatric asthma phenotypes and endotypes that they have characterized in their studies. We'll focus most of the talk on risk factors for pediatric asthma and what they've shown with these birth cohort data. Touch a little bit on a couple intervention trials that have come out of the consortium and some future research directions that we'll be working on. So the talk is, just to clarify for everybody, it'll be focused on pediatric asthma. So a lot of this research has been done in adults, a lot of what we've learned about phenotypes and endotypes in adults as well, but this will all be the pediatric asthma data. So in terms of the epidemiology and why this is important, among U.S. children under 17 years of age, asthma increased at a rate of 1.4% between 2001 to 2010, to give a prevalence in 2010 of nearly 10%, so a very significant disease that we're studying. It's the reason for 3.4 million physician office visits, almost 600,000 emergency room visits, and 150,000 hospitalizations in 2006. And in 2005, there were 167 unfortunate pediatric deaths from asthma. And of the 25 or 26 million patients with asthma, 7 million or 27% of those are children. So a significant disease that we need to study and learn more about. There are some racial disparities when we think about pediatric asthma and asthma in general. 74% are white and 18% are black.
Cristina, does the prevalence just include persistent asthma or any diagnosis of asthma?
I believe it was any, but I'd have to clarify, yeah. So why study inner city asthma? Why is this important and why was this established? Well, asthma is both more common and more severe in the inner cities. The urban environment has a high perennial allergen load. These are a socioeconomically disadvantaged population. Largely minority and high social stress situations amongst some of these families. And we know that children living in these low-income urban areas have high asthma morbidity and severity. So we'll next talk a little bit about the consortium, a little bit of the history. And so the inner city studies nationally were begun with these larger programs in 1891 with initiation of the Inner City Asthma Network program. Subsequent to that, from 1991 to 1995, they established a national cooperative inner-city asthma study. What this did was to identify environmental risk factors associated with this increase in urban pediatric asthma, and it really identified the cockroach allergy. as a major risk factor for asthma. Between 1996 to 2001 was the Inner City Asthma Study, which conducted a multi-center interventional trial to try and reduce the rates of pediatric asthma, looking at more environmental approaches. From 2002 to 2008 was the first iteration of the Inner City Asthma Consortium. It was created by the NIAID with a $62 million award to the University of Wisconsin faculty listed here. And then there were subsequent fundings from 2009 to 2013, $58 million, and then more recently, from 2014 to 2021, it was awarded $10 million per year for these ongoing studies. So a little bit more background. What it is a multi-study, multi-center initiative to study the causes of urban asthma epidemic and develop prevention and treatment strategies to help control pediatric asthma. It established a birth cohort, which we'll talk about a little bit later, called URECA, which stands for Urban Environment and Childhood Asthma. There are 10 clinical sites associated with these studies: Baltimore, Boston, Chicago, Cincinnati, Dallas, Denver, Detroit, New York, St. Louis, and Washington, D.C., and 3 basic science laboratories. The objectives overall are to identify risk factors for pediatric urban asthma, to characterize and understand the pathogenesis of these asthma phenotypes, to investigate the role of the host and home environment microbiomes in the development of this asthma, and then immune mechanisms that contribute to the development of pediatric asthma. And the hope then is to develop immunomodulatory approaches for the treatment and prevention of asthma, targeting some of what's been learned in terms of the phenotypes and endotypes as well. And just an overview is shown here in the schematic. And so thinking of, really this was a stepwise approach. And early on it was identification of these risk factors with the Inner City Asthma Study and Consortium. And then later on with the most recent iteration of the consortium, looking at cockroach immunotherapy, which we'll talk about a little bit later as well. So really focusing on understanding how all these risk factors interplay into increasing the risk and then what we can do to prevent it. In terms of the URECA birth cohort, this was a longitudinal birth cohort study in 4 inner cities: Baltimore, Boston, New York, and St. Louis. The selection criteria for the participant was that they had to live in neighborhoods where at least 20% of the population had an income below the poverty line. At least one parent had a history of atopy, including allergic rhinitis, eczema, or asthma. And the gestational age of the infant born needed to be greater than or equal to 34 weeks without any sort of significant respiratory problems neonatally. And pregnant women greater than or equal to 18 years of age were recruited during this prenatal period between 2005 to 2007. 1,850 families were screened, 776 met criteria, and 560 newborns were enrolled at birth and followed longitudinally. The demographics, in terms of the inner city population in this birth cohort, were predominantly ethnic minorities. 71% were Black alone, 19% Hispanic, predominantly Dominican and Puerto Rican, and 4% white alone. 17% of the mothers smoked during pregnancy, and 58% of these infants had smoke exposure at 3 months, so very early on. 68% had a household income below $15,000 per year, and 80% of these infants were born full term. 57% were breastfed at birth, and 24% at 3 months. And here's the study outline in terms of what they looked at throughout these different studies. There were questionnaires that were done prenatally, and then also at most of the clinic visits that they were done. And then blood samples were obtained from cord blood as well as at numerous clinic visits. And the clinic visits occurred typically about once per year. They analyzed illnesses when they were reported and also obtained nasal samples and then other samples for testing for viruses. They did skin testing at numerous sites and looked at 14 aeroallergens as well as food allergens as well. And they looked at pulmonary function testing at numerous time points, which is shown here. And then lastly, just to note that they did do in-home sample dust collection in which they looked at the levels of allergen in the home environment at these home visits. The URECA study had a two-stage hypothesis, which is shown here. The first one is that these environmental exposures in the urban environment are unique and that interactions with genetic factors during these prenatal and postnatal periods influence the immunity that leads to asthma and sensitization. And then secondly, that this immune dysregulation that's set up early on, both prenatally and then neonatally in infancy, increases the risk of developing lower respiratory infections, typically from viruses, which we'll talk about a little bit later, which causes lung inflammation during this really critical time of early lung development, and that also increases the risk of asthma. A couple other study cohorts I want to touch on, just because there'll be some comparisons in some of the studies. COAST is the childhood origins of asthma. This population was different than URECA in that it was a suburban population from Madison, Wisconsin and surrounding areas, mainly Caucasian participants. It was a birth cohort, so the children were born to parents with either an allergy or asthma history. 289 newborns were enrolled between 1998 to 2000, and 217 of those were followed out to 13 years of age. And then APIC, or asthma phenotypes in the inner city. This is not a birth cohort, it's a longitudinal cohort of children 16 to 17 years of age with just a broad spectrum of asthma diagnoses. They resided, in these low-income urban areas in 9 U.S. cities, which are shown here. A large population, there were 619 children that were included, and they were recruited between 2011 to 2013. They had more of a minority population. 64% were Black and 28% Hispanic.
And those other cohorts, did they have comparable samples collected, or?
Yeah, they all varied a little bit in terms of all of the clinic visits and everything, but it really just depended on some of the studies. But in general, there were numerous clinic visits, some sick visits, and then blood and sensitization testing. So we'll go through the data from a lot of these, and you'll kind of get a feel for how much was collected. I mean, I think one thing to appreciate is just the immense amount of work that goes into these studies, and I think that we've learned a lot from it. So I think it's very valuable. So we'll start to talk a little bit about phenotypes and endotypes in the pediatric asthma population. And this first study I wanted to review is from the asthma phenotypes in the inner city. So again, this is not a birth cohort. But what this study did was they characterized asthma phenotypes in these inner city pediatric population. And they looked at these different variables, 5 of them here on the right, down here. And then there were kind of sub-variables that they looked at within these to characterize the population. And what they found is that there were 5 phenotypic clusters of inner city asthma in pediatrics. And that these, the parameters they used to characterize these included asthma severity, pulmonary physiology, rhinitis severity, allergy, so sensitization and total serum IgE levels, and then allergic inflammation, which they defined as blood eosinophil counts and exhaled nitric oxide levels. And so these clusters, they denoted A through E. And so what they found in this abstract graphically that they show here is that there, as we would predict, there was a cluster in the population in blue here, cluster A, that had both low allergy and inflammation and had a very mild asthma and rhinitis. And then they found a direct correlation in clusters C, D, and E with progressively higher degrees of allergy and inflammation and then higher degrees of severity of rhinitis and asthma. And this is kind of classically what we think about with allergic asthma and Th2 phenomenon in atopic disease. So what was interesting that stood out is this cluster B population in green here. This population wasn't predicted, and they came out and found that these children had low allergy and inflammation, but they had severe asthma. And so the mechanisms of that wasn't classic to the Th2 and allergic asthma that we had understood previously. And so there are parallel relationships they showed that exist between sensitization and then these indicators of asthma and rhinitis severity, particularly in the C, D, and E population. but it doesn't hold true for every population. And so, I think from this we can learn that we can think about tailoring medications and treatments and prevention to some of these populations in the C, D, and E clusters, but in the cluster B, that this population might need something a little bit different in the future. Predominantly if it isn't an allergy or a Th2 phenomenon that's driving it.
So in that population, did they differentiate between eosinophilic and neutrophilic inflammation? What were they looking at there? And also leukotrienes have been associated with some clusters in adults.
Yeah, so this next study, we'll look at the endotype. Well, not this one, but the one after, we'll actually look at endotypes of some of these populations. And so they did look at like cytokine profiles of some of these different populations. But in this study, I don't recall the specifics of it. I think just in general that the eosinophil and the IgE were low, and that's why they thought they had low allergic inflammation or atopy.
It'd be interesting to know if the neutrophils were high there, if that's the...
Yeah, they could have. I don't remember specifically, but... So in terms of another population, so the difficult to control asthmatic, the study also from the asthma phenotypes in the inner city population looked at patients both difficult to control and easy to control asthma, and they define these by the amount of inhaled corticosteroid that the patients required. The difficult to control was greater than 500 micrograms per day of fluticasone, and the easy to control was less than 100. And there was a population in the middle that they didn't compare in this study. And what they found is that they wanted to characterize, what of the difficult to control asthmatics really defined that population and separated them from the easy to control. And those characteristics are shown here in the red. And so the greatest distinguishing characteristic was the FEV1 bronchodilator responsiveness. And other variables included the ACT score, the FEV1 over FVC ratio, rhinitis medication and symptom scores, the total serum IgE mold sensitization, BMI, and number of sensitizations. But what this really did was highlight the importance of allergen sensitization and also its sequelae, so rhinitis in pediatric difficult to control asthma, and particularly in thinking about long-term about treatment and prevention measures. So the next study then, again in the same population, looked at the endotypes, and so we learned a lot about adult endotypes. But I think this is an important study to think about these pediatric endotypes, particularly in the inner city. And what this study did was look at the cytokine profiles in these difficult to control asthmatics, the same ones from the previous study. However, this one looked at just the African American population. And what they found is they looked at numerous cytokines and then found 12 that were significant predictors of this difficult to control asthma. And that's shown here. And what they note is that there was a balance between Th17 and Th2 in these difficult to control asthmatics. And so on the left, you'll see the Th17 cytokines that were increased in the difficult to control. And then of the Th2, it was IL-5 alone that was increased. Whereas IL-4 and IL-13 were increased or higher in the easy to control population. So I think this really shows that it's a mixed response in these difficult to control, and that maybe it's in thinking long-term about therapies, it might not necessarily be one biologic, but a combination of different therapies to help control these asthmatics in the population. So one of the reasons to study pediatric asthma and to understand the different phenotypes and endotypes is to prevent long-term loss of lung function, and that's shown here in this diagram. And so what they did in this population from the Melbourne asthma study is to look at current asthmatics and compared to other populations. And what you see here is a decrease in lung function measured by FEV1% predicted, and that this decrease actually continues over time, and so there wasn't an improvement or regain of this loss of lung function. And this really occurs early on in these patients, and so it's critical to try and prevent it and this trajectory and loss of lung function. We'll move on to the risk factors that we've learned from the studies of these birth cohorts in the consortium. I'm going to start by looking at the first group, which are prenatal, postnatal risk factors, maternal risk factors, and nutritional risk factors I'll touch upon as well. This study came from the URECA population, and what it showed is that there were significant associations with an increased risk of asthma. And those included children in a family whose income was less than $15,000, a mother who smoked during pregnancy, maternal history of asthma, a low birth weight or slightly lower birth weight compared to those patients who did not wheeze, and then gestational age. And I forgot to mention earlier, so in the endpoints, or what was measured in the URECA trial clinically, was wheezing at years 3 of age, and then asthma at 7. And so you'll see a mixture in some of these data where in the URECA, this in particular in the URECA population, they measured wheezing at age 3, and then in other studies they've taken them out to an asthma diagnosis at age 7. The next risk factor is maternal stress and depression, and so what was shown here is the data from questionnaires, both prenatally and then postnatally at years 1, 2, and 3, and then cumulative. And what was shown in the black dots is a statistically significant increase in the risk for asthma for both perceived stress and depression, as well as hardship in these homes, suggesting that the well-being and health of the mom is also important in asthma risk. And I want to touch just briefly on vitamin D as a nutritional component. Prior to this study, both in the URECA and COAST cohorts, where they analyzed vitamin D levels in the cord blood, it was thought that vitamin D might have some component of influencing immunity, and whether that, the question was whether that increased the risk for asthma or wheezing in these patients. And so what they did is measured cord blood levels. There was no difference between both of these cohorts. Remember, the URECA, or the low-income urban cohort, and then the COAST, or the suburban Caucasian cohort. So the median cord blood levels were 20 and 21 respectively, and there was no significant difference in the levels and no significance in vitamin D, and whether that had an association with asthma in the future, suggesting that there wasn't any association between vitamin D levels and the risk for asthma. The next set of risk factors I wanted to look at then were the home allergen environment and allergen sensitization, particularly as we understand in this population there is a high allergen load and an exposure in the home environment in these urban settings, and also what the relationship between that is and sensitization, because we know that these children with urban asthma are largely a Th2 or allergic component to them. So this study here on the URECA cohort linked between home aeroallergens and asthma development, and what they show in the table on the left is the allergen levels of aeroallergen perennials, including cockroach, mouse, and cat, which are in the red boxes. And you see significance between the exposure to those in the home environment and an increased risk of asthma in this population at 7 years of age. And this was true in both the sensitized and non-sensitized children, and so that's segregated out here in the pink and blue lines. And so both the sensitized and non-sensitized had an increased risk, and that was correlative with the amount of exposure they had. And what I think was really striking that came out of this is the finding that it was higher exposure that was associated with a lower risk of asthma. And that this, in this population, when they looked at the wheezing endpoint at 3 years of age, what they found is that it's really an early and abundant allergen exposure that's protective against recurrent wheezing. And so here in the left panel, you'll see the number of allergen exposures up to 3. and then the probability of recurrent wheezing at 3 years. And you see this nice inverse relationship. And again, this is segregated out in both the sensitized and non-sensitized populations. And it's really an additive reduction as well. And then that this early exposure is actually important in prevention of recurrent wheeze, and that they didn't see statistical significance when they looked at the allergen exposed in year 2 and year 3. So really that 1 year early environmental exposure is important in terms of allergen exposure. The URECA cohort didn't note that dust mite was a risk factor, and possibly because the amount of dust mite allergen in these homes was actually fairly low. But I did want to just point out that there is another birth cohort, the Boston birth cohort study, that did find significance here with asthma and then allergic rhinitis in similarly in these kind of inverse relationship that higher levels were more gave it a higher increase in asthma. So even though that the dust mite allergen didn't come out in the URECA studies, there are other studies to show that there's also a relationship.
Did they split out the Denver cohort to see if it was different than the other cities for mite sensitivity?
I didn't review that, the Denver cohort. I'm not sure.
So in their discussion, how did they correlate that with earlier studies showing like mouse and rat exposure was inducing childhood asthma? So it appears to be the higher the levels, the better.
Yeah, it's more protective.
And it seems, then you got a population that's sky high in prevalence, but to a suburban population where you wouldn't have those exposures.
Yeah, I mean, I think something that they did discuss similarly is thinking about the hygiene hypothesis, and that this really, I think, kind of correlates along nicely with it, and that, in the farm studies that they found that higher allergen exposure was protective. And so you can get a similar environment in the urban environment.
But it's obviously not good enough to stem the high prevalence, which is much higher than a urban area without that exposure.
Risk factors, I think, that are occurring as well.
So in other words, sort of mouse, cat, and dog are a good thing, but the others are not.
Cockroach.
Yes. Dog trended, so if you look at the p-values were pretty close. So they did note that it did trend, it just wasn't significant in their study, but yeah.
It's hard to sort out. Christina, you may be getting to this, but they address the issues with antibiotic use risk and also acetaminophen use as far as linkage to asthma.
They might have, but I didn't review that literature. I don't know if
Remains a controversial.
I don't think in this study they did. They have another one, Dan Jackson, I think, looking at acetaminophen specifically. One thing to Bill's point that I think they discuss here is the timing of exposure seems to be so critical. That year 1 sample is collected at 3 months of age, and the thought is that why they see an inverse trend here compared to older studies is that they're really getting the sort of perinatal exposure as opposed to even at a year of age or something. At that point, exposure is actually potentially harmful, but it's that very early exposure that seems to matter in terms of tolerance. That's at least what they argue. And the trends weaken over time. And a lot of these families are moving and so forth. So what seems to be most critical is what they have in that 3-month period around birth.
We'll move on before the computer shuts off. That's okay. And then next, looking at sensitization, so not the exposure, but then those patients, or the population that's sensitized. So at the 3 years with recurrent wheeze, they did find that allergic sensitization was associated with recurrent wheeze, and that's shown here for all of the allergens. So again, that there might be a difference between what specifically allergens in the home environment they find are risk factors for asthma, but the sensitization could be any allergen. And again, that earlier time point is really critical in sensitization and increasing that asthma risk, which is shown here. And this is the coast cohort. So again, it's the urban cohort, suburban cohort. And what they found is that children sensitized to more than one allergen by a year had a 65% asthma rate. And that's shown in this orange population here. And then that this rate was lower if they were sensitized later. So between 1 and 5 years of age, they had a 40% asthma rate, which is the population just below here. And then in those that were unsensitized by 5 years of age, so a little bit later, they had a 17% asthma rate. And that rate was, if they were sensitized after 5 years of age, was the same as those who were never sensitized. So again, really, that earlier sensitization under a year of age was critical in increasing the risk of asthma in this population. The number of sensitizations correlates with asthma risk, and so when they looked at the different allergens that they were sensitive to, an increasing number of sensitizations also increased the probability of asthma at 7 years of age, and this is in the URECA birth cohort. So the next story I wanted to move on to from these studies is a viral story looking at rhinovirus as a risk factor for asthma, and then a little bit about the genetics and kind of predisposition of different genetic alleles into pediatric asthma. So in the coast cohort, when they looked at the different viruses that are found during wheezing illnesses, what they found is that rhinovirus, which are shown here, RV A, C, and B, the three types of rhinovirus, accounted for nearly 50% of these different wheezing illnesses. And again, in this population, they just analyzed which viruses were present when they had illness or sick visits, which I think is pretty striking. And we discuss a lot about the risk factor RSV, but rhinovirus actually is associated with a lot of these illnesses. And then also to note that Rhinovirus A and C were more predominant than Rhinovirus B, which was over here, and is definitely a minority of the causes for these illnesses. And Rhinovirus A and C are more likely to cause a moderate to severe illness in infants, which is shown here again in the coast cohort. And so they did this mainly by questionnaire and looked at the children that came in with these wheezing illnesses. And of those with moderate to severe illness, the majority are the A and C rhinovirus and not the B. And this is both true for the species and the different types of rhinovirus. And another study subsequent to this then showed that these more severe wheezing illnesses actually confer a greater risk for asthma long term. And rhinovirus A and C also cause more asthma symptoms, which is shown here in the first panel. And this was also a study from the same group recently this year in Jackie. And so when they looked at rhinovirus A and C, there were more significant symptoms in these patients, cold symptoms, asthma symptoms as well, which is shown here in figure B, and then in C, asthma exacerbations. And that's compared to rhinovirus C, which is here in green. And then again, multiple rhinoviruses were detected. They also had an increased risk, or increase in the symptom burden and exacerbation. And these wheezing illnesses with rhinovirus are a significant predictor of early asthma. And so in the coast population, when they looked at asthma at 6 years of age, and those that had wheezing illnesses from RSV only, rhinovirus only, or both, what they found was that the rhinovirus was a greater predictor of asthma at age 6 than the RSV, with an odds ratio of 9.8 versus 2.6, so a fairly large difference. And these wheezing illnesses in the first 3 years were actually the most significant predictor of asthma by age 6 in this population. wheezing with rhinovirus but not RSV was also associated with persistent asthma into adolescence. So the last study looked at just wheezing early on, but this looked at later time points, and what they found is that there was significant at the majority of the time points with rhinovirus, and that risk of asthma into adolescence was much greater than the patients that wheezed from RSV, suggesting that rhinovirus is actually a very important respiratory pathogen as a risk factor for the development of asthma in the population in pediatrics.
Do they culture the kids' noses to get rhinovirus, or do they culture their airways?
Nose, I believe.
But in the city populations, I'm curious about that Rhinovirus B. Was it just as prevalent as the other strains?
Oh, I don't know about the prevalence of it overall. I'd have to go back and look, because I know that they did culture from sick and non-sick visits, so I'd have to go back and see how much of it they saw overall.
It's definitely lower. I think actually the previous slide, you can see that in the numbers. They're the one you were just on.
Oh, sorry.
300 RBA, 100 back one, 100 RBB, and 118 RBC.
Oh, the number, yeah.
And that's
right.
similar. They have another study where they look longitudinally, sampling every 2 weeks from kids over a year, and it's very similar, where you see predominantly RBA and then RBC, and it's slightly higher than RBB usually.
But is there something about what's known about the immunopathogenesis of rhinovirus B? Is it less inflammatory? Or?
Yeah. So I mean, Jim Gurn's done a lot of work on that, basically showing that it elicits less of an immune response. It often, I think, has it's in the airway longer, but is really more of a sort of.
But is there been some investigation of why? I mean, is it less effects in the lower airways, or what's? I mean, that sort of thing.
The answer is yes. I don't know. I don't know all the details of it, but they've worked out a fair bit of pathogenesis. Part of it has to do with how they enter the epithelial cell, I think, and the receptor is known for RBA and C. We should pull up his stuff, but he's worked out a lot of that in molecular biology.
And on that same line of questioning, can the respiratory viruses, can they attack the lower airway, or are they strictly upper airway? The rhinovirus. Are there receptors on the lower airway for rhinoviral infection, or is it all upper airway receptors?
The same receptors exist, so like it's CDHR3 is the receptor for RBC. You have that in the upper and lower airway. I don't think in any of their studies do they look at a lower airway sample. He's always looking at an upper airway. Okay. I mean, from other work, we know that you can see these infect lower airway cells, although I don't think it's common in these kids.
And then in thinking about the viral infection with sensitization, that there's additive effects. So in these patients with early sensitization, when they looked over time at years 6, 8, 11, and 13, that there was an additive effect on sensitization and rhinoviral wheezing illnesses. And so you see, if you look at just the year 6 data, in the patients that were sensitized alone, their risk was 3.9. And then in rhinovirus alone illnesses, it was higher, 7.8. But you saw an even greater increase in both if they had both. And that was an odds ratio of 45. So a fairly large difference. And again, over time, you see that this really kind of marches out this increased risk when there's both sensitization and a history of rhinoviral wheezing illnesses, suggesting that it's an interplay both between allergy and sensitization and then the environmental risk factors. And then to get a little bit about kind of the pathogenesis and how some of this is being mediated, one study from the group looked at rhinovirus A and C and the bacterial burden that they found during these illnesses, and what they found is that rhinovirus A and C, but not B, were associated with an increase in bacterial burden of pathogens such as Haemophilus influenza, Moraxella, and then strep pneumoniae, and that's shown here. And so rhinovirus C was associated with an increase in H. flu and Moraxella, and then Rhinovirus A was associated with an increase in also H. flu and then strep pneumoniae. And Rhinovirus B was actually not associated with an increase in bacterial detection. So suggesting that if there's an increase in the bacterial burden associated with these viral infections, that might mediate inflammation and some of the symptoms of these wheezing illnesses as well.
Did they correlate that then with like frequency of otitis or sinus disease? I mean, is there a linkage? You would think there would be.
I'm not familiar with that, so I'm not sure.
I mean, the relevance of that is obviously sinus disease can make asthma worse.
Yeah. I don't think they necessarily talked about the severity in terms of, whether these developed into pneumonia or something like that in the same study. I think it was more just that they found them concomitantly there in the airway, but not necessarily that this bacterial pathogen alone was responsible for a significant illness. And so this was kind of what Matt had mentioned. So thinking a little bit about genetics and what a lot of these risk factors mean in terms of a population that might have an underlying genetic predisposition. And so the first paper from Nature Genetics in 2014 found that the CDHR3, which is cadherin-related family member, had an unknown host function, and the study actually looked at different genes that increase the risk of asthma in these populations, and they found a polymorphism in the CDHR3 listed here that was associated with a greater risk for severe asthma in the pediatric population, and also the number of hospitalizations. And so that's shown here. This is a CDHR3 polymorphism, and you see an increasing risk associated with increased hospitalizations associated with this allele. And what was really nicely shown in this story by Dr. Gurn's group is that this actually is a host receptor for Rhinovirus C, and in a subsequent study in PNAS, and that this variant confers an enhanced viral binding and replication, which is shown here in HeLa cells. And this receptor is expressed on the mucosal epithelial cells, the respiratory mucosal epithelial cells. So suggesting that there is this variant that increases the likelihood of a severe exacerbation, and that is associated with asthma risk, which I think is a really nice story.
And is that a fairly frequent variant, or and also is there any disparity between the African American population and Caucasians?
Yeah, that's interesting. I don't know the frequency of it off the top of my head. I'd have to go back and look and see.
It's certainly not rare. It's on the order of tens of, more than 10%.
Significantly more in Africa.
I don't know the ethnicity that they worked that out. I don't think they've looked at it.
Do you know where these studies that he did? This is Jim Byrne?
Yeah.
Was this the Madison population?
Well, no, because the Nature Genetics isn't his paper. I don't remember what. I think that's maybe from Australia or something.
Yeah.
This is not an inner city population where this was found.
Yeah, the initial isolate in Nature Genetics was not those were cohort studies. It's just the original paper describing it. And I'm not aware whether he's looked at the birth cohorts in terms of the frequency of the allele. But what I think, this really exemplifies is that, something we talk a lot in medicine is that, a genetic predisposition and then environment on top of it can increase the risk for disease. And I think this really nicely exemplifies something that we talk a lot about in terms of disease pathogenesis. And then just to kind of finish this section on risk factors, when we think about these different risk factors and the pathways and how they can lead to asthma severity, they looked at the population and the asthma phenotypes in the inner city and analyzed these different risk factors in terms of, how do you get to asthma and different asthma severity phenotypes. And this is a very very busy diagram that they came up with. They looked at significance, which is shown here, in that the dark black lines are significant associations between these different risk factors and environmental factors. And I think just the take-home message is that there's multiple pathways that can contribute to asthma and the development of asthma. The allergic sensitization, they suggest, does seem to be an initiating factor, and then we've learned that this early sensitization is very important under a year of age, and that allergy can act through more than one pathway in terms of asthma severity. And it's really kind of the host, genetics and environmental factors that lead to asthma, and then the phenotype of asthma as well. There's a couple intervention trials that I wanted to review quickly that's come out of the consortium in terms of, one of their main goals was to look at prevention and treatment of pediatric asthma. The first was the trial omalizumab, which was a randomized controlled trial published in 2014. And what that showed is in children that were treated with omalizumab, that there was improved asthma control, both in the number of days that they had symptoms and exacerbations, which is shown here, compared to placebo. Omalizumab in children eliminated the seasonal peaks, which we typically associate with asthma exacerbations, so both in the spring and the fall time, which is shown here in the red, and the placebo with the peaks. Reduced the need for hospitalizations, and then also inhaled steroids, and the steroid data is shown here. And that, I didn't show the data, but there was greater efficacy in children that were sensitized with cockroach or dust mite, which is important thinking of how these allergens are important contributing factors to the development of asthma. And then, so prior to this, omalizumab was approved at age 11 and older, and this study included participants down to age 6. So again, I think that this was an important study, showing that omalizumab is a good treatment in the young pediatric population, particularly with difficult to control asthma. And then this was a pilot study that was done by the Inner City Asthma Consortium in 2014. It was published, and what they wanted to look at was an interventional treatment. And so they are looking at, and they're currently studying as well, cockroach immunotherapy. And in this pilot study, they looked at sublingual immunotherapy to cockroach in the adult population, in a pediatric population, and then compared it to subcutaneous immunotherapy. They measured IgE, IgG4, and then blocking antibody. And what they wanted to do was to compare the different kind of endpoints, or how immunologically active these different treatments were. And what they found is that the subcutaneous immunotherapy seemed to have more immunologic activity, and that it had a greater IgG4 response and blocking antibody as well. And there were no serious adverse events, which was something else they wanted to study before pursuing a larger trial, which they're currently doing at this time. So that data will be to come. So I want to touch briefly on the last section on future research, kind of what the preliminary studies from the consortium have shown, and then some of the questions that we're looking at together. So this next part is looking at, we've kind of talked about already allergen exposure, sensitization, and how the home environment plays a role in asthma development. But then also thinking about the environment and the home environment in terms of the microbiome. And so not only the microbiome of the host, which we'll talk about here, but we'll later also talk about the microbiome of the environment. And so there were a few studies that have come out recently that have linked the gut microbiome of the host to an asthma risk. And overall, what they show is that there's an overall dysbiosis, which is a relative change in the microbiome diversity in these patients, but not the composition. So the types of bacteria are typically the same, but you see an increase or decrease in the amount of them in children and patients with asthma or a history of recurrent wheeze. And so one study showed that there were 4 bacterial genera that were reduced in children with wheeze or atopy, which are listed here. In children with asthma, Another study showed a lower abundance of the two bacteria here, and then a higher abundance of some fungi. And then another study showed that gut Bacteroides colonization very early on at 3 weeks of age was associated with a positive asthma index, which again would suggest that possibly Bacteroides, both the amount and then an early colonization, might have an association with asthma risk. And one study out of the URECA cohort showed is that not only a low allergen exposure, but low dust microbial exposure was associated with atopy. So the converse would be true then. A high allergen and high dust microbial exposure would be more protective against asthma, which is shown here in this figure from the paper. And so when they looked at patients that either neither had wheezing or atopy, those that had recurrent wheezing measured at 3 years of age, or those that were atopic at this age, or both, they looked at then the amount of allergen and the amount of microbial exposure in the home dust environment. And if you recall early on, I did mention that they went on home visits and collected the dust and then measured the microbiome in these dust samples. And what you see in both the wheezing and atopic population is a higher percentage of those that had the lower exposures. And that in patients with neither, that they had environmental exposure that had a greater richness of the microbiome as well as allergen exposure. There does seem to be some sort of association between the two of them together in terms of asthma risk. And then this is was kind of further studied in a more recent study this year that came out looking at, again, the URECA cohort. And what they looked at was more specifically the taxa in the homes of children, and they found kind of in this plot that those with asthma had an increase in certain types of bacteria, and then compared to those without. And if we look at one in particular, say if we zoom in on Bacteroides, what you find is within that family that there are different types of Bacteroides that also are associated with or correlative with a change in the allergen exposure. And so, like if you look here in the red, some of these are associated with, say, an increase, this filled black dot would be an increase in the cockroach allergen here. And then some were associated with lower allergens. And so in the future, kind of understanding what is it about these particular bacteria and the crosstalk between that and the allergen exposure in particular. And it would be specific allergen exposure like cockroach to increase asthma risk in these patients. And so the couple questions that we'll be working on together with the consortium is looking at how these exposures influence immunologic pathways to asthma, and then specifically what associations are present between the allergen levels in the home, in the house dust samples, the microbiome data, which I just showed you, and then peripheral blood transcriptome data to looking at different cytokine levels and different gene networks that come out of these patients, and kind of what is the interplay between all of these three different networks to increase the risk for sensitization and asthma in these patients. At the end of my talk. Any additional questions?
Seems like the old literature, if you had a dog in the house, you were protected with kids, and if you didn't, you weren't protected. And it looks like these inner city things, dog's not really important as cockroach and dust mite. Is that sort of the feel you got from this?
Yeah, I would say mainly cockroach, I think, is kind of the allergen that is important in the inner city, and then dust mite depending on the environment as well. And I know that's why they're focusing on the cockroach allergen in terms of the trials as well. Yeah. But it does trend in terms of dog and cat. You do see similar trends in terms of the allergen exposure and whether it's protective.
It's a little odd, though, because, again, it's sort of very early exposure is protective, but very shortly thereafter, once you're sensitized, and then if you're exposed, it's very harmful. So some of their earlier work, decades ago, was about sort of cockroach remediation in the home, and that didn't work, and it's probably bad because sometimes it's cockroach exposure is beneficial, and then other times it's harmful.
Yeah, and if you look at the gut biome, they used to say the kids on farms would eat feces, so they had all these weird organisms and they were protected, and then the kids that didn't live on farms got sick and there was more asthma. It's just, it all goes in a big circle.
Too many variables.
Yeah.
So what we're trying to do like that, we have data now showing sort of in certain kids, basically those who get asthma, where Bacteroides sort of induces a Th2 response. In others, it sort of prevents it, and so then trying to also understand, what's different about those kids, why some respond positively and some negatively.
I don't know if the extracts have changed, but we're getting a lot more positive cockroach samples now. So I actually called Tom Greer, and he says you can mix cockroach with most of the other allergens, and it won't interfere with them. Because I was trying to figure out whether this is safe to add, or is it like a mold and it's going to eat up the other allergens. And he said no. But I didn't remember seeing as much cockroach as I do now. Now it seems like everybody who's positive cockroach is one of their allergens.
Yeah, we rarely see that. It's just from
People
just
who
more
live
than
here all their life.
Well,
More people moving.
very few people have lived through all their life. But I don't know that I didn't stratify that in my head whether they're from
So you
here
just
or
don't
not.
see cockroach.
I mean, the people who came from Louisiana, obviously cockroach doesn't surprise you, but the people that are here. We have American cockroaches here. Actually, in inner city is pretty significant, but it's not the German ones. It's actually the American cockroaches. Just in case you want to gross out your
Nicer
friends, you can tell them. Yeah. Nicer cockroaches. Yeah. They drink coffee.
That culture.
Is, Matt, is Eric Wambre at Benaroya looking at Th2As in these populations?
So we're not. The consortium actually works with Alex Setti at La Jolla, who's the other sort of tetramer, MHC2 tetramer guy. So he's been doing that sort of in parallel, where they're taking, they're basically trying to determine what is a major allergen in cockroach.
But they're not specifically looking at Th2A population?
Well, actually, he does. He has the ability to do it. I don't know that he's done it with these samples at all. That was just published that gene panel. So I don't know how widely it's been used. He uses the same CD154 activation to look at acting on Th2, but he hasn't defined the Th2A the same way that Wambre does.
I was just bringing that up because at the Benaroya, Wambre has had a very important paper in Science this past summer, and in a variety of allergic situations, from clinical samples there from the BM, there's this activated Th2A subpopulation that have characteristics of both super secretors of IL-4, 5, and 13 plus IL-17 cytokines. It's got a CD161 phenotype that's more like a Th17 cell or a natural killer cell, but it'd be, because your slide when you showed that mixture of cytokines, it was a mixture of Th17 and the Th2s, and that's exactly what these cells are pumping out a lot of. And it'd be important because it looks like the COX-2 pathway is super activated in these cells, so they're producing a lot of prostaglandin D2, and also CRTH2 is an important effector. So there's new therapies against both of those. So for interventions, if they were to show that population was skewed in the inner city pediatric population, production of those, I mean, that's down the road, but that would give a different intervention too. So.
Yeah, I mean, they're starting a cockroach immunotherapy study, and they'll be collecting samples for Alex to look at post IT. So I'll actually chat with Alex about that specifically. The mission is to Th2 and so use the Th2A profile.
finding it. You know, so. Well, good job, Christina.
Very good.
Pretty tough topic.
Yeah.
Complicated.
Everything you want to know about asthma and the microbiome is not too hard.
That's a hard slide to kind of grab
I know.
onto.
I was just looking at that going, that looks like how they predict birth date. You know, they got that wheel. And it's like,
You imagine down 20 years we'll be going with these microbiome
Yeah.
with
that's right.
patients. Where your bacteroides
That's
is
right.
out of whack here.
We'll start sounding like the naturopaths here. Oh, yeah, you'd be all better if you would just eat this yogurt.
Always I don't know how you get 100 people.
Oh, really?
Just got to get the right people. I mean, I've done about 5, 6, 7 patients. So it may take half a year, but
That's right.
we'll do it.
So are you a physician then?
Yeah, I mean, it's just like on the way out, you know? From the very end, you're just
That's right.
riding it out.
Oh, sure.
How you doing?
What's MSL? Is that
I'm gonna have
Little southern term.
I was going to say, I haven't heard that one in a long time, and I know exactly what it means, but I haven't heard it.
oh, did you?
The rain has been heavier than
That's
normal.
where you want to go and just practice like your practicing condition. Let's just get temporary.
Pouring down.
But it's not that normal misty rain that we get.
Well,
It is a
It's
big,
like a winter rain.
yeah, it's a big
Experience
drop.
on both sides, right? On kind of like
I love
Oh, he,
And
well,
he was here for all like this beautiful. It was cold,
Oh.
and he was complaining that he had to scrape his drawer. So
Oh, poor man.
we got him on a windshield scraper.
how did you Christmas? You have any
So your
clinics?
minister is based out of Hawaii?
He's moving here,
Around here in
and
Seattle?
so yeah, the day after he leaves,
Yeah, absolutely.
he would have experienced that.
he would have
huh?
experienced
Which awesome.
Yeah.
So you got one in Bellevue now? He did. So that was just pretty recent, right? Over the last year or so?
I was gonna carry out this out.
No, you can't do that.
Copy all over myself.
Okay. Cool. So were you based
Uh,
out of
what are you doing
Portland,
for Christmas?
Vancouver, or okay?
My family's here,
Yeah, I was
actually.
down in Austin.
So you're staying here?
So
Yeah,
that was
we're gonna down to my sister's house. Going down to Portland
without it.
tomorrow.
Good luck.
Yeah, if we can.
You know, it might be worth your while, take the ferry over to the peninsula.
and then head down. Avoid 16.
Oh, they're saying everything is best for you.
Okay, yeah.
Everything is best. I'm not sure it'll be open up this weekend.
Yeah.
a lot of reading there.
It is going north.
Yeah, no, I feel really
It's
good.
fine coming
Yeah,
this
north
way.
is fine.
Down there.
Really?
I don't mind taking it.
And that's what I would.
Yeah.
I know it adds an hour.
Probably send that to us anyway, though.
Yeah, I mean, add an hour.
It's pretty fun. Yeah.
Oh, I can do it.
We have a friend who plays for the Blazers, so I'm thinking I might out to see him play.
Oh, that's nice.
He's famous for surfing's her favorite
Nice to meet you.
team. Nice to meet you. She doesn't even know where I'm
Don't
from.
know
New
those
York.
random You don't know why.
Yeah. That's about it. Besides, it's just kind of knowing regular,
Yeah.
you know.
Regular family things, right?
Just like hanging out watching the bowl game.
Wonder if
I think it's
yeah, 67, 167.
Yeah.
Okay, maybe I'll go with you.
Okay, sure.
Oh, thank you.
Reinforce my